Top Med Talk.
Hello, I'm Desiree Chappell, and this is Top Med Talk. As the coronavirus pandemic continues, we continue our conversations with care providers around the world to continue to shed light on the crisis. Our series, Coronavirus from the Frontline, highlights healthcare workers on the ground and those taking a more supportive role in an attempt to share their stories in hopes to provide education and support for all of our listeners. Now, I'm in Louisville, Kentucky, and I'm joined by our editor-in-chief in London, England, Monty Mythen. Hello, Monty.
Hi, Desiree. Good morning. Welcome to good morning for your time. Welcome
yes.
to another week in lockdown in the UK. You still locked down at your end?
We are still locked down. Yep, we are continuing the conversation about opening things up. I know several of the hospitals in town are starting to gear up for elective surgery, and businesses are slowly going to start opening in the next probably week and a half.
And that's definitely over this week. Yeah, over this weekend, that's definitely how the conversation shifted. I mean, the healthcare system is still looking pretty similar. There's a lot of very sick patients, a lot of people working extremely hard in there. But the general mood is the fact that a little bit of the sort of surge of COVID has softened a little bit. We saw our Prime Minister back in front of number 10 today. He'd been unwell. He'd been hospitalised and in intensive care with COVID-19. And he, after a few weeks recovering, is now back out in front of number 10. He's telling us the lockdown is going to continue, but he's also sort of saying that they'll be sharing plans for easing the lockdown, which is that's good news for everyone. They know it's going to be a while, but they're talking about the next phase coming soon.
Yeah, Monty, there in London, do you feel like there's been a softening, I guess, of a surge of patients? I mean, are you still seeing kind of the numbers?
Yes, I think all the reports suggest that is so, that the numbers of very unwell patients aren't growing, which is a good sign. If anything, they are in London. They're decreasing a little bit. Now, that's still in lockdown, if you see what I mean. So the next thing is, as the lockdown eases, which you get the impression that even though we're supposed to be in lockdown still, that people are pushing their luck a little bit more than they did before. I don't know how to phrase that correctly, but you know what I mean?
I think that's it, yeah.
Yeah. Perhaps stopping to chat with each other more on the streets, even though they're trying to keep their distance. There's a little bit more potential for people getting infected there. But we haven't seen any secondary blip. And when they truly ease it, that will be the next test.
Yeah. Well, it's probably not a bad thing, actually, to start bending things just a little bit. So maybe not jump full feet in.
Yeah, you have to be careful. You can't advocate that, but I think the social scientists have predicted, the social scientists have predicted that will happen by default anyway, and that's part of the thing that everyone's scanning and screening for. And there's discussions now about the use of apps and different tracking devices and mechanisms as well, and there's mixed feelings about that.
Yeah, here too. Monty, can you speak to the rest of the country? I mean, what's happening out in Greater England and some of the more rural areas? Are they starting to see a little bit more flare-ups as things maybe moved out that way?
Everyone's seen the spread and the surges in different ways. We saw the heat map of the spread in the country as the metropolitan areas, which have the densest populations, understandably see more of it, and it sort of goes hand in hand. But I think everyone has seen some COVID-19 patients now.
Mm-hmm. Well, Monty, to further our global conversation and get the perspective from Ireland, our next guest is from Cork, Dr. Jan Brohan. Hello, Jan.
Hi, Desiree. How are you?
We are doing well. Jan, you are a friend of the EBPOM family. We all were at Dingle this past year with the Ireland Association. Can you tell us a little bit about your background, what you do, and the association that you are affiliated with there in Ireland?
Sure. So I'm a consultant in anaesthesia and intensive care medicine, working in Cork University Hospital. I joined there about 2 years ago, and prior to that I worked in the UK, where I spent a year in intensive care medicine, and prior to that 2 years in Canada, and prior to that some time in New Zealand. So I guess we're talking about a multinational training base. When I returned to Ireland, I joined the organisation of the South of Ireland Association of Anaesthetists, who have buddied up to the traditional Dingle conference, which has been going on for 20 years or more. So we knew where our bread was buttered or how to run it. So we joined a very successful conference model. And for the last, Monty would know more than me, the last 5 or 6 years, there's been an input from the South of Ireland Association of Anaesthetists. So I joined that as the secretary of the group. And then last year was my first year of being part of the greater organising committee of the EBPOM Dingle meeting. And my main joining the faculty there was to improve and enhance the input of Irish faculty and speakers in the Dingle conference. Because there always was, even though I've been going to Dingle for a number of years now, it always has been a mystery to me why it is taking place in the west of Ireland. It's this wonderful nook in the west of our country, but it largely had a majority of input from the NHS delegates as opposed to Irish delegates. There have certainly been Irish delegates historically, but I aimed to enhance that and to enhance, I guess, input from both countries into this conference, which I hope it did seem to reflect in terms of the increase in Irish delegates to the Dingle conference in total last year. So that's, I guess, my input, hopefully.
We were just discussing before we got going, Jan, that the meeting is definitely on this year. Now,
that's great.
It's a meeting in October. For all of our EBPOM meetings, we have decided not to cancel or postpone any of them, but we do understand the fact that we may not be able to physically meet or all physically meet. We're anticipating that within countries we'll be able to get together by then. Who knows what will exactly happen. But we're on, if you see what I mean. So I just really hope we can physically be there, because I'm not sure.
Yeah, I do too.
There's a lot of people that are really wishing that we can be in Dingle in the fall.
You and I briefly had touched on how the virtual pub would work. So let's see.
Not quite as well.
Such are the challenges.
We can all drink Guinness anywhere we are. It's definitely not as good.
It doesn't travel well. It's true.
It does not travel well, no, but it is amazing over in Ireland. Well, Jan, I remember whenever you were presenting and talking about the Southern Ireland Association and how it was like Cork and non-Cork for the rest of the country.
Well, see, this is the thing. People are used to looking at a map of Ireland where it's like North of Ireland and Republic of Ireland, but the Cork, not Cork, is the important one. That's the one to get your head around.
That's right. So your group is really focused really just on that southern area, and then I would imagine
exactly.
There's the rest of Ireland, or do they all have their
own? There are other anaesthesia groups within Ireland. There's the Eastern, and then there's the Western group. So it's more regional areas within Ireland.
Yeah. Well, it was, I've never been at Dingle before. It was really great to have the Irish perspective, just to hear about the culture of anesthesia and perioperative medicine in that country, for sure. I know that there are a lot of meetings all over the world that happen in really cool places that never have representation from where they are. So having that Irish voice in there, I think it's really important and made it really unique. So.
Oh, I completely agree. And the conference really does envelop and embrace just parts of our culture. It being in Dingle and Monty having heritage in the Dingle area. So I think it's important that we have input into it as well.
Jan, you locked down fairly promptly in Ireland, and I think the doctors, with regards to COVID-19, had quite a big influence on that. Now, not everyone will understand, but as I understand it, you were making a transition from the existing Prime Minister, the Taoiseach, who was a doctor, is a doctor, if you see what I mean, to that being undecided who was going to lead the country, because you'd had an election and you were sort of left in limbo for a while. What happened on that front? Well, one is, how quickly did you lock down? And the second one is, what's happened about the leadership? Because you seem to have done, by European standards, a good job on the whole COVID-19 thing compared to how some people might see other efforts.
That's right. I guess in the government aspect first, our election was, I think was the end of January. And there wasn't a single party that reached the critical number of seats to have a majority government. So then what happens in that situation is the outgoing government maintains sort of an interim government before there is a new government formed from a series of talks between other parties. So we have continued to have a government or a leader in the government role as things have progressed. So
that's
the
Dr. Leo Varadkar, is that right?
Exactly, yeah. So the Taoiseach from the preceding government has continued on as interim Taoiseach, I guess, if you want to think of it that way. So there has continued to be leadership, which I think is a key feature in how we have dealt with this, because you were quite correct in saying that we locked down pretty early. Our first case in Ireland happened, I think, just at the end of January, the start of February, with our index ICU case, which was actually in my hospital in Cork University Hospital. Our index ICU case was in the first week of February, and we locked down, or started locking down, just before St. Patrick's Day.
That's a big decision. I mean, that's a big, bold, in hindsight, an excellent decision, because, some of the events here went ahead. And some people argue that we were a bit slow off the mark with that.
Well, I guess if you look at footage or you listen to stories about St. Patrick's Day in Dublin or in Cork or any of our urban centres, on any given year, there is an element of inebriation on the streets, mass inebriation, to say the least. And there was a lot of pressure put on the government in social media websites, as well as our own ICU bodies, the Intensive Care Society and the Joint Faculty of Intensive Care Medicine, as well as other training bodies such as the College of Anaesthesiologists. Pressure put on the government to close down pubs in advance of St. Patrick's Day, and to close down the country in advance of that. So we locked down, schools were closed the week before St. Patrick's Day, and then there was more stringent lockdowns towards the end of February, with the current measures, which are non-essential travel banned and not leaving home except for essential activities and staying within 2 kilometres of your home.
Jan, can you tell me how many cases have you guys seen in general, just a roundabout figure? Do you know, is it in the thousands, the tens of thousands?
In general, we're in around 17,000, 18,000 nationally now.
Oh, okay. And do you know how many deaths, just roundabout hundreds?
600 or 700 deaths at this stage. Our numbers of deaths, unfortunately, are continuing in around 30 to 40 per day. And our cases are continuing to be in around 700 or 800 per day. But the pocket of cases now is largely in nursing homes and care facilities, unfortunately. Yeah. So that continues to be an issue. Community transmission has ultimately been dampened. Our R0 was down to less than 1, whereas at the early stages it was greater than 3. So social lockdown and social distancing has worked, except unfortunately our care facilities and nursing home facilities continue to be an issue.
Group home settings are taking a huge hit. I think that's the second wave of it. It's terrible. Jan, talk about your hospital. Maybe not your hospital specifically, but just in general, did they stop doing elective cases when they pretty much shut everything down and shut the pubs down? Did you continue to do elective, or, what does that look like for you guys? I
work in a tertiary referral centre for trauma as well as cancer surgeries. So we have divided things into emergency surgeries, which obviously can't be delayed. There's a certain amount of time-sensitive surgeries that have to have continued. So they are mainly cancer surgeries. But essentially elective surgeries have stopped. And there is talks now of similar to what you were talking about earlier, about how to get that going again, because they can't be stopped forever.
Have they kind of strategically trying to plan that out, or have they really gotten into that of how they're going to start opening up the elective cases?
They are talking about opening up full theatre capacity from next week, essentially. But within that is the limitations of PPE, because theatre staff needs to be protected as cases progress, in addition to the droplet precautions that bring delays into theatre throughput. So I think surgeons, I've realised as time progresses that unfortunately our theatre efficiencies, whereas a lot of us would say they weren't so efficient, are going to be less efficient as time goes on because of all of those aspects. So
you can't necessarily just snap your fingers and say, okay, back to normal.
So whereas theatres are going to be open for business, it's hard to know how much business they'll manage to get done.
In the hospital, did you go for full mask wearing amongst all your staff or not? It's a question I keep asking around the world, because there seems to be quite a variation in it. We do not seem to have done so in London, whereas in Harvard, for example, the Brigham, they went very early. They went in March to full mask wearing, on this idea of the fact that you can get it from anyone and give it to anyone. What was your approach?
Yeah, our approach was was more like the second that you described there: full mask wearing and PPE for the start of every case, when the droplet potential is at its highest, when patients are being intubated. In addition to a certain time period following airway management before other people get into theatre to allow for droplets to drop. And then for at-risk procedures such as thoracic procedures, laparoscopic procedures, full PPE for people in theatre. So that's becoming more and more of an issue as our PPE stocks have been diminished. And there's, like other countries, there's less and less of a supply being brought in. So that is an ongoing issue, like elsewhere.
Have you decided to quarantine anybody before they come into surgery as you're starting these elective cases? I mean, do they have to have any time period of like kind of strict quarantine?
That is a protocol that's, as we're looking to step up activity, has been recently devised and revised. And essentially it is a case of a chest x-ray 3 days before their chest x-ray and a swab 3 days before their surgery, 3 days of a quarantine following that, assuming their swab was negative, and then into theatre. But what hasn't been decided, even if with those new protocols, is the reduction in PPE requirement for the staff in theatre. So it hasn't gotten around, or the guidelines haven't decided to step down on the PPE wearing for staff.
Do you have testing capacity? Are you in any way restricted?
That has dramatically increased. So this week, what's been quoted is that we're going to be expanding to 100,000 tests per week in Ireland, which is a massive increase. So we have massively increased our testing capacity, which is the next step, right? As you're trying to release the social lockdown and release the restrictions, you have to have more efficient tests. We don't have these quick turnaround tests right across the board as yet, and you need to increase up your capacity for testing.
Jan, do you guys have the antibody testing? Have you started doing any of that?
We haven't started, no.
Monty, are you guys doing that much?
There's not so routinely yet, no. I mean, there are still great debates about what you can make of the fact that you can find immunoglobulins that attach to coronavirus, but whether that confers immunity or not, that will all be happening as part of the vaccination program development, because having antibodies per se doesn't necessarily mean that it deals with the virus. It just means that you've got something that sticks to the protein. Yeah, that's the big challenge. And it might, if a whole load of people go and test themselves and say, well, look, I've got some IgG and IgM knocking around now, then they might start misbehaving a little bit more, which might drive up the infection rates again. So the science is relentlessly ongoing, and there's a lot we just still don't know. Like, despite having the lead time from China, there's a lot of known unknowns.
Jan, can you speak to the number of, or not necessarily a pure number, but like the healthcare workers and the infection rates for the healthcare workers there in Ireland? Because it's a concern, everywhere.
Yeah, for sure. I don't have an up-to-date figure for healthcare worker infection rates in Ireland. I don't have the national numbers, but I know locally in my hospital, with our index case, who happened to be an intensive care patient at the time and had been for a number of days, that his positivity took out 30 or so ICU nurses, not in terms of positivity, but in terms of OC health advice that they needed to go straight away into self-isolation. So that was a massive stress to our ability to provide intensive care for the rest of our patients. From that time, there was 2, possibly 3 nurses that were positive, and fortunately are actually now fine. And we've had a number of physician staff members as well that have been positive and have gone through self-isolation. None of them ended up needing hospital admission, thankfully. But it is clearly an ongoing issue in terms of, and it's one of the major challenges I've found during all of this, is continuing on managing the patients you need to manage and increasing your bed capacity to meet the surge, whilst managing attrition in terms of staff numbers due to suspected or confirmed positivity. So that was one of the major challenges over the last period, as well as looking after these critically unwell patients that can be a real clinical challenge.
Jan, are the patients, COVID patients that you've been taking care of, you said that you have some in your ICU there. Have you, the conversation has been around how we treat these patients, with the ventilation as well as hemodynamic management. Are you seeing kind of the same profile as what you were hearing kind of globally, that it's kind of actually not a traditional type ARDS stiff lung kind of thing?
Yeah, for sure. For sure, there seems to be a spectrum, or there just seems to be different phenotypes. What we have had patients that would meet the traditional model of ARDS with incredibly stiff lungs and needed to be proned really, really rapidly. And only after a certain period of making sure they were absolutely negative in terms of fluid balance and that they were unproned for a series of days, did things start to improve. We also had probably the atypical model of these patients, whereby they had impaired gas exchange without stiff lungs, that they had a pure oxygenation issue without it being a compliance issue, which I know is the mystery of this disease. So I guess we've seen both, but it's certainly not a homogenous group. It's certainly not, I think, in 10 years' time, there'll be an intensive care textbook written about what was the clinical definition of COVID-related ARDS. I don't think we will get that.
The hemodynamics that you guys are dealing with, a lot of the cases that we've seen, it's if they have to go onto a ventilator and they require that escalated care, that their hemodynamic management is just very, very intense and very difficult to deal with. And trying to keep them on the drier side is actually working against us, especially when it comes to advanced renal dysfunction and things like that. Have you guys seen that as well?
Yeah, well, it is, of course, because as these patients can be more difficult to ventilate and oxygenate and need higher PEEP that increases their intrathoracic pressure, which means that they need an increase in their circulating volume and need to expand that volume as much as you don't want to for gas exchange reasons. So it is difficult. Passive straight leg raising is something that I've integrated into my ICU ward rounds to help determine, is this a situation that is amenable to a fluid bolus? Because the traditional methods of looking at capillary refill and feeling are the patient's hands warm or not, and it can be misleading, and you ultimately will end up relying on excessive doses of vasopressors if you don't consider at least some degree of fluid expansion or volume expansion. So it can be a difficult one because it's sort of a catch-22. You're looking at which is the lesser of two evils here, and quite often these patients can end up on quite high vasopressors because you decide the lesser of two evils is to dry them out, drive up their vasopressor requirements in an effort to help dry out their lungs.
Yeah, I heard one of my colleagues say the other day, Jan, which has been a long time since I've heard it, because I'm old enough to have treated the compliant lung ARDS back in the days when we only had Manley ventilators, so we know they weren't very stiff lungs. But I wrote it down during a virtual ward round. He said, I gave some fluid to get the SATs up. So he was making that observation that if you do the straight leg raise and the saturations improve, that there's a VQ mismatch, but it's on the Q side, not the V side. So he actually wrote down, he said, I gave some fluid to get the SATs up. There we go. How the world changes.
Oh, there's a quote for you. That's great. Well, Jan, thank you so much for chatting with us. It's so important.
No, delighted. Anytime.
Yeah, to have these perspectives from all over the world. It's good to know that we're all, experiencing the same thing, so that there's a lot of lessons to be learned, and they are transferable to everyone around the world, because it's kind of the same conversation. I hope things open up there in Ireland and that we're able to get in there for Dingle.
No, me too.
It's going to be good no matter what, but it'll be nice to be on the ground.
Maybe but we should have a session on post-traumatic stress disorder amongst physicians following coronavirus.
Absolutely. Well, actually at Dingle last time we had a conversation about a little bit of, wellness with care providers and after traumatic events and things like that. So I think that it's definitely something we're going to have to talk about, because the strain just on the nurses and the physicians having to take care of this.
Right, yeah.
It's immense. And, not to diminish that, but there's a lot of stress that's happening for people just having to be at home, worry about finances, all of that. So a lot of stress going on for sure.
We'll deal with it in Dingle.
I think there's enough Guinness over there to help with all
there is.
My mum lives in southeast London, who's originally from Dingle. She, I tried to contact her yesterday and she said I can't, because she goes to church at Dingle She watches the service there every Sunday.
Isn't that lovely?
So it's a lovely service as well. It does a great job. So it actually says, "No, I can't talk to you now. I'm at church." from Southeast London to Dingle.
Yeah, that's great. What a great idea.
That's fantastic.
Well, Jan, hopefully we'll be able to connect with you here in the coming months to see how things are progressing in Ireland. And
anytime.
Thanks again for
fantastic.
chatting with us.
You guys stay safe.
Top Med Talk.
Be sure to check us out on topmedtalk.com for more interviews like this and conversations with all of our guests from all over the world. You can also find us on social media, Twitter, LinkedIn, Facebook. Stay safe, stay well. We're all in this together. Thanks so much for listening.
Top Med Talk is proud to thank its sponsors, specifically Edwards Life Sciences, for their generous support through this global crisis.